I'm gonna start with the basics, and then we're gonna go through all the electrical therapies so that you know how to do it. All right, so the first one I'm gonna show you, I'm gonna put ventricular fibrillation, and we're gonna show you how to perform defibrillation on this monitor. So I'm gonna put VFib. The defibrillation will be the most simplest, right? You could point here, right? That's fine. You could point here, right? Yeah. So defibrillation, right? So you're gonna come to this monitor, and this is your selector switch, right? When we're performing defibrillation, don't say I'm gonna shock, just say I'm gonna defibrillate. This way we know that you're actually meaning defibrillation as opposed to synchronized cardioversion or something else. When you say shock, it's ambiguous. But when you say I'm gonna defibrillate, I know exactly what you're doing. What is the joule setting that we're gonna employ? Max, right? In your REMAC protocols, I know they will say 360. This is a biphasic monitor. The max it has is 200. So you'll see on this dial, it's gonna go up to 200. So I'm gonna move this dial all the way up, right? All the way up on the dial. And then what I'm gonna do is I'm gonna charge this monitor, right? For me to deliver this, right? All the pads have to be connected, right? To the patient, the pads, and also the electrodes, right? We're gonna make sure the patient is clear. So at this point, you're gonna say, right, I see ventricular fibrillation. I confirm there's no pulse. Everyone stay clear, right? And then as you observe the patient, you're gonna hit this button, which will essentially deliver the shock. Make sense? If the patient stays in this rhythm, you're gonna then proceed with your pharmacological therapy. If you need to defibrillate a second time, the procedure is exactly the same, right? You're gonna keep your selector knob switch at the highest setting, charge again, right? Verify that no one is clear, right? No one is touching the patient, right? And then you're gonna shock. So that's defibrillation. Any questions about how to do that, right? The next one I'm gonna show you is, I'm gonna show you a patient who has ventricular tachycardia. So I'm gonna switch to ventricular tachycardia. You're gonna see, right, how the monitor switches. You see, right? How do I know it's ventricular tachycardia? It's wide complex, right? And I see my heart rate is no longer fluctuating. This is another tip for you guys. If the heart rate is jumping about like 160, 200, 180, probably dealing with irregular rhythm. Why is it jumping? Because it's sensing R2R progression, and it's not able to say it's regular, right? But for ventricular tachycardia, the rate is going to be about 150. And is it regular or irregular? Regular, right? Very good. What is, if the patient is unstable, right? You're gonna say, right, what's my mental status? What's my blood pressure? What's my vital signs, right? Patient is altered mental status, has chest pain, shortness of breath, hypotension, confusion, BP 60/40. We're gonna go with unstable, right? Unstable protocol. We're gonna shock him, right? But don't say shock, we're gonna say cardiovert, synchronized cardiovert, excellent. And the reason why I have you say it is because the moment you say synchronized, we gotta do what? We gotta press sync button, right? The sync button on this monitor is right on this at the top. Everybody see that? It says sync. We're gonna hit it. The moment I hit it, it's gonna start to flag my R waves. You'll see these white marks as it's detecting the R waves, right? And why do we wanna do it? Because we have a precision time frame when we're delivering the shock to terminate the dysrhythmia. We're gonna start with 100 joules in accordance with the REMAC protocols. So the selector knob switch, I'm gonna move it to the 100 position, right? And then what I'm gonna do is the procedure is gonna be exactly the same, right, as in defibrillation. We're gonna charge it, right? We're gonna verify again, right? We have ventricular tachycardia on the monitor. Patient does have a pulse, right? We verify the patient does have a pulse, patient is unstable. I'm gonna say everyone's clear. We're gonna deliver our energy. And then we're gonna observe the monitor for evidence of the cardioversion. Meaning, does it break my rhythm, right? If this doesn't break the rhythm, what are you gonna do? Repeat at what joule setting? 200, right? So you're gonna go at 200 joule setting, right? On this monitor, it doesn't dump the sync. What I mean by that, you see how the sync is still blinking and it's still engaged? On the other monitor, the LifePack 12, it will dump it, so you have to resync it every time you wanna synchronize cardiovert. But this monitor, it doesn't dump it. So you see how it's still flagging? Right? I'm gonna, again, charge. I'm gonna verify that patient has ventricular tachycardia, patient still has a pulse, right? No change in that condition, right? And then I'm gonna say everyone's clear, and I'm gonna deliver the shock, right? Then I observe the monitor for evidence of cardioversion. If the patient, let's say, had the same rhythm but had no pulse, all of a sudden, what I'm going to do? CPR, and then we're going to defibrillate. For me to defibrillate, I have to remove the sync feature, right? So I'll just say no pulse, start CPR, I remove the sync feature, and then I'll move it, keep the dial at max joules, and then defibrillate. Now, this monitor can only go to 200. So you want 100, 200. If I wanted to synchronize cardioversion the third time, what I'm going to do? Keep it at 200. I want to keep it at 200 because I don't have 360. I don't have any more. I don't have 300, 360. So I'm going to keep it. So synchronized cardioversion is performed for fast rhythms above 150. Defibrillation is only performed for 2 rhythm, despite what you may have seen on TV, right? I know you guys on TV, they show you a systole and they defibrillate, right? For this class, we defibrillate 2 rhythms. You could write them down. One is ventricular fibrillation, and the second one is pulseless ventricular tachycardia. There's only 2 rhythms you defibrillate. You do not defibrillate asystole, you do not defibrillate AFib, you do not defibrillate anything else, despite what you have heard or seen, right? For synchronized cardioversion, we defibrillate more rhythms. They're usually fast in nature, above 150, and they have hemodynamic instability. They cause hemodynamic instability for the patient. So like supraventricular tachycardia, ventricular tachycardia, any white complex tachyarrhythmias, right? Make sense, right? Any questions about how to synchronize cardioversion and how to defibrillate? It's clear, right? The next one is going to be transcutaneous pacing. And this one is a little complicated because of the modes they are. I'm going to tell you the basics first, and then I'm going to explain to you the complicated stuff. Why? Because you're going to eventually encounter it, and you're going to have like hard time processing it, right? So just come over here. I'll show you, right? So before I show you the electrical energy, right? Remember we talked about how to measure blood pressure, right? The formula was cardiac output times what? Systemic vascular resistance, right? Yes? So and cardiac output formula for cardiac output was, right? Everybody agree with it? If I basically, I take the same formula, what I'm going to do is I'm just going to like break it down like this. Blood pressure is a makeup of cardiac output and, right, systemic vascular resistance. And this cardiac output we can further subdivide into stroke volume, right, and heart rate. This side of it deals with usually with systolic blood pressure, and this side of it deals with diastolic. So let me explain to you. Imagine you have a patient, right? We got this guy. He had a massive heart attack, right? And he's now in cardiogenic shock. You come, you assess him, and we're gonna say he is in a 3rd-degree heart block, and his heart rate is 50, right? So let's say his heart rate is 50 beats per minute, where his normal heart rate was 75, let's say, right? So we can see based on this, his heart rate is down, right? Yes? So if his heart rate is down, his cardiac output is down, his systolic blood pressure is going to be down, and ultimately his blood pressure is going to be down. Right? And when you guys are going to come to the station, I'm going to hear the following from you guys. Okay, heart rate is 50, patient is saturating poorly, blood pressure is, let's say, 60 over 40, right? I'm going to start IV access, I'm going to give him 1 liter of fluids. That's what you're going to tell me. Is that the correct choice? Why not? They have pump failure, but so what's the problem with that?
So you're giving them more fluid when their heart can't pump it, and it's might kill them.
So exactly. So you may have a backup. You may have backup of that fluid, and you have pulmonary edema, right? So in the setting of a 3rd-degree heart block, right, on that patient, right, initially we want to correct his heart rate because his heart rate is not enough to sustain the cardiac output. So we're going to externally pace him, which is called transcutaneous pacing, right? We're going to set our pacemaker rate about 20 to 30 above the inherent heart rate, right? Roughly speaking, right? So I could set his heart rate to maybe 70 beats per minute here on the machine, and I'm going to see if this is going to correct my blood pressure, right? And what we want, right, even doing all this, our main goal is usually, right, we want the mean arterial pressure, the MAP, to be greater or equal to 65. right? Anyone know why we are looking at, like, why is it has to be 65? Anyone can tell me?
That's a demarcation for shock, right?
But why we want it to be greater or equal than 65?
Isn't that the amount of pressure the heart needs to push against in order for the blood to flow?
Specifically, yeah, to the brain, right, to your cerebral circulation and to your coronary arteries. If you don't generate that pressure, blood is not going to your coronary arteries, right, the vessels that supply blood to the heart, and it's not going to your cerebral circulation, it's not going to your brain. That's why we got to get a map of 65. So let's say I have the same patient, third-degree heart block, heart rate of 50, right? We start pacing him, right, and maybe his blood pressure was initially 60 over 40, and we got it with all this, we got it to, let's say, 70 over 42. Right? We're still not at our goal of map. We're still not there. Anyone, can you guys calculate? I'll show you. So the map formula, right, if you guys still remember. Right, so 2 times diastolic blood pressure plus systolic blood pressure divided by 3. So here we got 70, right? So 2 times 70, which is 140, plus 42. Oh, 42, correct. Divide by 3. Can anyone pull out the calculator and tell me what the map is right now?
51.3.
What is it? Can you say louder?
51.3.
51.3, right? So 51.3. So we did help him somewhat, right? We went from this to this, but we're still not at 65. And we're already pacing him. We already fixed his heart rate. So now, from which side of this formula I gotta attack his blood pressure? From the systemic vascular resistance, right? How do I do this? Right? So you could have dopamine, right? But basically, in the setting of cardiogenic shock, per your rheumatoid protocols, when they give him 250 mLs of saline first, reassess him. You could repeat another 250 mLs of saline and reassess them. That's your max dose, right? Max dose is 500, not giving them 2-3 liters of fluids. And if that still doesn't raise my MAP to 65, I gotta go with the pressor, right? So let me show you this on the board so that you guys can see, right? So then, right, we're gonna give them a pressor. It's from your protocols, right? Remember this chart I was showing you guys, right? So our goal is to increase systemic vascular resistance, and that's what gonna increases blood pressure. Which receptors I want to target? Alpha 1, right? So I look at alpha 1 where I see the most pluses. Where do you see the most pluses? Huh? You see epi, right? And you see norepi, right? So if I wanna vasoconstrict, these are 2 medications that are the best, right? But you notice, right, with epi, you also have a lot of beta 1. So I may increase his heart rate higher than I want to. He just had a heart attack, he's in cardiogenic shock. I don't want to increase his myocardial oxygen demand. So maybe the best drug is norepi, right? Because it's only 2 pluses for beta 1 response. Make sense? Right? So this is how we're gonna attack this, and once I'm gonna give them the 500 ml of fluids, then I'm gonna give them a vasopressor, titrate it to the effect. This is how we're gonna basically bring up his blood pressure to get perfusion going to the heart and the brain, right? When an epi can be more effective, I'll show you in your REMAC protocols one thing, so I'll show you this, right? In your REMAC protocols, you see in your medical control options, right? You have administrations of epi starting at 2 mics, right, up until 10 mics, right? And you also have dopamine, right? So usually, and you have various doses, right? So usually this medication here, right, the epi, the reason why they have this, the major reasons why they have this, right, if you notice, is primarily this. If you cannot get electrical capture on your monitor, so meaning you cannot pace with your machine, and I'll explain to you why that may occur. You could chemically pace them. You could give them a medication, right, epinephrine, that's gonna drive their heart rate. But can I actually dial in what's the heart rate I want with epi? Can I say I want a heart rate of 70 with epi drip? Why not? Well, I don't know what. And give me more specifics. You're correct, but why?
Because you don't know if they have endocrinology, like endocrine problems, and like medications that are going to block the receptors. Yes,
good. So they may be on beta blockers, right? Or the response of their receptors may be upregulated or downregulated. So I give him epi, his heart rate may be 120. I give her epi, her heart rate may be 90. I give you epi, your heart rate may be 150. I cannot control that. I cannot control it with my dosage. It's patient specific. In the setting of a heart attack, right, and MI, ST segment elevation, maybe I do not want to, cause too much harm. That's why I want to use my monitor. But if I cannot do that, and I have no choice, and I have to increase your cardiac output to get blood flow to the brain and the heart, I may have to go with the pharmacology, right? But the first option is what, right? The first option is what? Pacing, right? That's why they have it listed here as initially, right? You see how it says begin transcutaneous pacing, that's before, right? And we're also going to give atropine 1 milligram. Even if you have third-degree block, you're still going to give it to see if it's going to work, right? So you're still going to give atropine, and then you're going to go with transcutaneous pacing. So I'm going to show you how to do this. So I'm going to set a third-degree heart block here. Right? So I set a third-degree heart block. It's going to take a little bit of time just to drop the heart rate, right? So you're going to see, right, atrioventricular disassociation. Usually third-degree block is regular rhythm because ventricles is beating at its own rate and atria is beating at their own rate, right? And at this point, right, you determine the person, let's say, has a pulse, their altered mental status, blood pressure is, 60 over 40, right? We got to start pacing. Heart rate is 50, right? Heart rate is 50, right? So what I'm going to do is I'm going to take the selector knob and I'm going to move it to the pacer. The moment I move it to the pacer, you have a new menu that appears, right? It's not pacing yet, right? You're just going to input the stuff. So what I'm going to do is I'm going to select my rate, pacer rate, and I told you about 20 to 30 above the patient's inherent heart rate. So it was 50. I'm going to put it at 70. How to adjust it? Up and down arrows, right? So it goes up by 10. I'm going to select 70. I'm going to put a check mark, right? And then you have pacer output. That's how much energy you're selecting. When you turn on the monitor, it's going to be set at 10. And we're going to slowly increase it until we get electrical capture. Electrical capture is usually, you're going to see, the droid here. For electrical capture, you're going to see a spike followed by a white QRS with a T wave. So white QRS with a T wave, this is how I know my ventricles have depolarized. Because I have white QRS and a T wave tells me that they have depolarized. Make sense? Yes? All right. So I'm going to come here. I'm going to see that, right? I'm going to first initiate my pacemaker. Here, you have two modes. You have a fixed mode and you have a demand mode, right? Has anyone heard about fixed and demand mode? No? Yes? What do you know about them?
Pacemaker only works when it needs to work.
Yeah.
It's fixed, it always sits there.
Excellent, right? Excellent. And what do you think is the default mode when this monitor is turned on initially?
Fixed.
Demand. So when you initially turn on, the mode is demand. So I was adjusting it, right? That's why it says fixed here. But when you turn it on initially, the pacer mode is demand. And I'll explain to you what this is. Demand mode is it's going to work with the patient's heart rate. If the patient's inherent heart rate is less than what you set it to pace, it's going to pace. The moment patient's inherent heart rate exceeds the number that you preset, it's going to stop pacing. It's a safety feature. Why? Because if it continues pacing, like in the fixed mode, you're going to get RNT phenomenon. And they can go into VTEC or VFib, right? So let me show you how it looks. So now I am in demand mode, right? We set the rate at 70. It's flagging the patient's heart rate. You see how you have white marks above the QRSs? I'm going to say start pacing. And the moment I click start pacing, you see these marks start to appear on my EKG cycle. And my goal now is I want this waveform to look like that at the top. So I'm going to increase my pacer output slowly until I get, right, something that looks like that we call electrical capture, right? I'm going to go a little faster because I know what the threshold is so that you guys can see. So now I see a pacemaker spike and I see a QRS and I have electrical capture. I want to give the least amount of energy to the patient to not give him discomfort. So I'm going to go down 5 and I'm going to see if I still have capture, right? And it looks like I still have capture. I'm going to go down to 50. See if I have loss of capture, and I have a loss of capture. You see how it stops those? It's not looking like that anymore, right? So I know I got to go up. I got to go to 55. And the moment I go to 55, I have capture. I'm going to click check mark, and you're going to see my heart rate is going to elevate to 70. Because what is this heart rate we set it to? 70, right? So I confirmed I have electrical capture. That's what you're going to tell the instructor. The next, I got to confirm mechanical capture. Mechanical capture is how the heart contracts. So I'm going to check my central pulses, right, femoral or carotid, and it has to match what? The heart rate here, right? I also want to check the blood pressure, because if it's working properly, maybe from 60 over 40, my blood pressure is now 80 over whatever, or maybe 90 over whatever, right? So I do a vital signs. Also, you want to compare it to your pulse ox, right? You're going to put it on the finger, right? And the patient's heart rate is going to appear on the monitor right here. They should match too, right? Because if I have adequate flow, right, I should have matching of this, right? So you will see, right, it will say my saturation, right? And it will tell me my heart rate, right? My pulse rate right now, it's going to come down, but you'll see it in blue, that's my pulse rate. They're not going to match right now, because obviously my heart rate is not what's the mannequin's heart rate, right? But for your patient, they should match. The other very good thing you can do is, if you have your stethoscope, you put it at mid-clavicular, fifth intercostal space, and you should hear what? Lub-dub, right? That's one beat. You're going to count that, lub-dub, lub-dub, lub-dub. If in a minute you got 70, you got what? Mechanical capture, right? Sometimes it's very hard to feel the pulses, right? Why? Because when the milliamps are going through the chest will contract. Because the energy will cause the thorax muscles to contract, and it's very hard sometimes to feel the pulse. So you take your stethoscope, fifth intercostal space, mid-clavicular line. Everybody follow what I'm saying? Right? Feel their skin. It should be getting warmer. Feel, right, the peripheral pulses, if you get pulsations. If your map is not 65, we're going to go with what? Right side, right? 250, 250, and norepinephrine. Norepinephrine, right? I'm going to show you guys how it looks all of a sudden. Let's say patient's heart rate elevates, right? So you see how it's pacing? Let's say you're transporting, you're driving to the hospital, all of a sudden patient has normal sinus. So watch what happens to the EKG. You see how it stops pacing, but it's still flagging the heart rate. The patient's just converted to the sinus rhythm, right? I didn't have to do anything with my monitor. It detected that the patient's converted, right? No issues. Let's say I was in the fixed mode, right? So let me go back into a 3rd-degree heart block. So I'm back into 3rd degree, and machine automatically starts to pace because it's now dropped below the preset rate, right? Everybody see that? So what I'm going to do now, I'm going to pause pacing. I'm going to put a fixed mode. So pause pacing, and I'm going to select pacer mode fixed, right? So we're in a fixed mode. I'm going to resume pacing, right? And all of a sudden, right now, everything looks fine, right? Like before, no problems. You're transporting. Patient converts to normal sinus. See what's happening? It's still pacing. It's still pacing, right? And right here, this would have been RNT right here, right? You see how some of the pacers, right, are falling on the T wave or the R wave, and the moment this occurs, you have a higher chance of getting RNT, right? Now, my other question: what if this is a dangerous mode? The initial mode is demand. Why even have it? You need it. The manufacturer decided to put it for no reason. So what I'm trying to tell you is this: when you turn this machine on, it's in demand mode. Demand mode is the most safest, as I showed you, right? It will look at the patient's heart rate. But there's a fixed mode. Why have the fixed mode? If someone's what? Pacemaker fails, but I could put them in the demand mode. Any other ideas? Tell me. You could guess. No idea. Yeah. So what I'm saying is, in that case, I could still go in demand mode. What I'm saying is, why have fixed?
What about pacing for somebody with people alive for organ transplant?
Okay. All right. So they have the inherent heart rate. Yeah, you could have that, right? What else?
Can you set the threshold for demand?
Can you set up threshold? Yes.
Okay, so that's if you could maybe if you needed it like a faster rate than demand.
And why would that be important? So you're on the right track. Like, your thought process is sound. Tell me why it's good.
If somebody needed, like if they needed a higher heart rate to get perfusion.
So you're on the right track. So what she's saying is this: maybe a patient has a high heart rate, right? And we can use this. Before, back in the day, they used to terminate taking this arrhythmia, like SVTs, with this. They would set a fixed rate. They would increase the patient's to the rate above the patient's heart rate. So let's say patient is 160. I'm going to put it at 180. I'm going to get capture, and I'm going to bring down the heart rate. So they used fixed mode, right, for that reason. Because if you were in demand, it would never pace, right? But the moment I put it in fixed, I can go higher than the patient's heart rate, get them captured, and then bring down their rate. The other reason, you may have interference. Sometimes you go to, like, especially if you're doing like helicopter transfers, right? HEMS, helicopter EMS, you may have interference. You don't see really clear-cut, right, QRS complexes. So you'll put it on a fixed mode to basically not use the R-wave trigger. You'll basically have the machine working as is. Another reason could be is, imagine you have a patient whose R-wave is not like this, whose R-wave is like this. Actually, let me come over there because you'll not be able to see. So imagine the patient's heart, instead of having like the R-wave that's like that, you have R-wave that's almost identical to the size of the P-wave. Like that. So the R-wave, and you cycle through all your leads, and all your leads are like this. The machine doesn't know what's P, what's R, what's T. And it cannot initiate pacing, right? And you could cycle, you could select which lead you want, 1, 2, 3, 4, 5, right? But if all your leads looking like this, it will have a hard time doing that. The other thing is, look, I'll show you something else. See, it's pacing in, right? So let me just switch into a 3rd-degree heart block in a second. Another reason is this. So I'm still in fixed mode, right? I'm in a 3rd-degree heart block. It's pacing, and what I do is I remove this connects to my electrodes, right? The limb leads, salt, pepper, ketchup. Right? You see, the EKG is not displayed, but it's still pacing. I don't know, it's pacing. You see the pacemaker spikes? Still pacing. The electricity is conducted. Like, now, if I go to the demand mode, so now I'm in demand mode, and this happens. See how it says pacer stopped working? And these are no longer marching through, right? It tells me to connect it. Why? So I disconnected them, right? So in the demand mode, right, it cannot both read and provide electricity through pads alone. But in the fixed mode, I can provide electricity through this. So let's say for some reason your cables are no longer working or you forgot them, you could have still paced through the fixed mode. But if you were in demand mode, you could no longer pace them. Right? Any questions about this? So what is the most safest? Demand, right? Which mode are you going to stay in? Demand, right? Is there a real reason for you to switch to this? Probably not, right? Unless you have really big R effect, or your R waves look like that, right? Or you do not 800 your vehicle and your pads are not there. But know that if you keep it in the fixed, you may get RNT phenomena. And then without this, you don't even know what the rhythm is. Everybody follow? Right? So, any questions about anything I showed you? How to pace, defibrillate, cardiovert? Right, you guys know your skills? All right, good.